My task today really for the coming 20 minutes to cover some new aspect about rituximab therapy in glomerular diseases. Now, everybody really is jumping on the bandwagon of rituximab use, and there are a lot of uses and abuses for this. Let me just start with, now what's rituximab basically? Rituximab is a mouse human chimeric monoclonal antibody directed against CD20 protein expressed on the surface of the B cells. As you'll see here, the B cells and usually on its surface there is the CD20 protein, and basically rituximab is a murine. The variable region binds specifically to CD20 on the normal and abnormal cells. And now once it's really being bound, it activates the body of immune system which attacks and kills both normal and abnormal cells. Now just what's monoclonal antibodies, as really cleared here in the red you looked about, this is the mouse. It's basically all immune monoclonal antibodies are derived from mouse, non-human species, mouse and rats. And then by engineering, humanized engineering way, usually being humanized to various degree of engineering by substituting some of the amino acid terminal present in the variable region, make it minimize really the normal one. So in the left corner, you see 30% when the whole variable region is changed. That will be chimeric. And when you have few part only, and then the top right side, 10% that we call humanized. Now, how it works really? It works by identifying the CD20, and then it binds to it, and after that the cascade of immune suppressive mechanism will start the activation through the antibody, antigen-dependent cellular cytotoxicity, complement, and apoptosis. What really we mean by the antibody-dependent, which is the major site really of working that, the antibody binds to the antigen on the surface of the cell, and then the killer cells, or the CD18 receptor, recognize the antibody bind cells, and then after that, stage 3 will be cross-linkage of the CD18 triggers dysgranulation and lytic of the cell itself, and then the tumor cells will die by apoptosis. This really occurs also among normal cells. Now, what's the adverse effect of rituximab? As we know, it's hypogammaglobulinemia can occur, late onset neutropenia, impaired vaccination response and infection. But talk about the infection really from our point of view as nephrologists, it's really the least it happened, but it's more and more with hematological malignancies. What are the contraindications for the use of rituximab? Active and chronic infections, severe heart failure, and then pregnancy. And pregnancy really by the 8 to 16 weeks of gestation, the blood crosses the blood placenta barrier, and at term it's 3 times higher than the mother's serum, and then that's why really FDA advocates contraception under rituximab therapy and should be continued for 12 months after that. Again, FDA recommends rituximab use when there are no other alternative during pregnancy, and it's not really clear how much it can be excreted in the breast milk and if it is harmful or not. Now, where we stand really with this use in patients with glomerulonephritis. We know that there are good evidence for B-cell involvement in the development pathogenesis of ANCA vasculitis, lupus nephritis, membranous nephropathy, IgA nephropathy, and cryoglobulins. And to a lesser extent, we don't know much really about B-cell involvement in the pathogenesis of minimal change disease and focal segmental. Let's examine some of these just on the coming minutes. How we really manage ANCA-associated vasculitis and where is the role of rituximab? Well, the principle of therapy, usually remission induction, and that's basically for the first 3 to 6 months, and then remission maintenance that needs really between 18 months and 24 months. The guidelines always recommend the use of steroid therapy as the first time, and then cyclophosphamide with high glucocorticoids for all patients with severe disease as the first line of guidelines recommendation. Rituximab with high corticosteroid is recommended as first line when cyclophosphamide is contraindicated or the patient is not really preferring the use of that. And plasma exchange, it has its role, but this is not our topic. Now, where we stand with the ANCA-related vasculitis. There are a couple of randomized controlled studies, the Rave and the Rituximab. Now, the Rave trial, it's a randomized placebo-controlled multi-center non-inferiority trial compared Rituximab with cyclophosphamide as an induction therapy. In patients with severe ANCA, around 75% of them, they were GPA, and 25% of them used MPA, and 51% of them, they had relapsing disease. As you'll see here, 99 patient Rituximab arm, and oral cyclophosphamide 98, all of them they received steroid therapy, the same, but Rituximab was given 375 milligram per square meter weekly for 4 dosages, and the oral cyclophosphamide given 2 milligram per kilo for 6 months, and then followed by azacitidine. What's the primary endpoint? Primary endpoint was remission of the disease by 6 months and maintained remission through 18 months. 6 months, 12 months, 18 months, there was really no difference. And the adverse effect, there is no difference, but in the subset of patients who have been relapsing and the treatment was given for them, there was a good evidence that really Rituximab was superior to the cyclophosphamide. And there is the other study, Rituximab, which compared cyclophosphamide, Rituximab, as an induction therapy also. They have 44 patients divided into 2 groups, 1 to 3, Rituximab group 33 patients, and control group 11. Both received prednisone initially, IV, and then Rituximab was given again 375 milligram per week for 4 weeks, coupled with IV cyclophosphamide, 2 dosages, compared with the control group cyclophosphamide. The primary endpoint was sustained remission at 12 months and the adverse effect. Look what happened. Sustained effect, really the same. Adverse effect is basically the same. Death is the same. So basically the conclusion now, both studies, in such patients, they said it's really severe ANCA vasculitis and Rituximab trial, proven that a single course of Rituximab was as effective as continuous conventional immune suppressive therapy for induction and maintenance of remission in such patients for 18 months almost. And then what about maintenance now? That's for induction. Well, there is a nice study really. They have 115 patients were randomized, 1-to-1 randomized to receive either Rituximab or azacitidine and followed for 28 months. All such patients were really given initial therapy until they have remission. After remission, they are divided into 85% aza and 75% Rituximab, and Rituximab was given as 500 milligram on day 0, day 14, at 6 months, 12 months, and 18 months post-inclusion. Azacitidine was given initially 2 milligram per kilo for 12 months and then gradually tapered. Prednisone was given at the same time. Look about what happened. Long-lasting remission and very few relapses occurred in the Rituximab group, and relapses around 3%, 3 patients, 5% in comparison to the high percentage of that. Not only that, but the rate and sustained remission of ANCA patients were much better and superior at 60 months with Rituximab, either the survival 58 versus 38%. So that's the story with the ANCA related. What about membranous nephropathy? We know that membranous are being classified as mild, moderate, and severe, and regardless of the initial management, when you decide really to give immune suppressive agents, KDIGO guidelines recommend cytotoxic agents, cytoxics, and prednisone, that's Ponticelli protocol, or calcineurin inhibitors, that mostly accepted ones. But on the other side, far right, Rituximab, MMF, and steroids came into place. Do we have really any standardized studies? Well, we have observational studies that from the Romuzzi group in Italy, when they looked at 100 patients with primary kidney disease, membranous nephropathy in almost 68%, where the patient previous immune suppression were treated. They received Rituximab, 2 doses maximally, and what happened really after that. Look really on the top, partial and complete remission was really achieved, and in the group with primary therapy, 69% improvement, and in the second group, when they have really initial relapses, it's 58%. Proteinuria, as you notice, continued really to be low up to 60 months. And there is another study comparing retrospectively, observational study, with cyclophosphamide and the steroid. Look about the adverse effect, really. Primary endpoint was serious effect, partial and complete remission. Adverse event, the same. Serious events, basically, maybe better in the rituximab group. Complete remission and complete endpoint, no difference. They concluded here that rituximab may be safer due to its safety profile as a first line of therapy in such patients with membranous nephropathy. Then we have a couple of randomized controlled trials, placebo-controlled and then calcium urine inhibitor controlled, but unfortunately there is no head-to-head study of rituximab with cyclophosphamide-based therapy. The GERMAX study here, it's a basically randomized controlled, placebo-controlled, when they have 75 patients after being included with the maximum treatment we call non-immunosuppressive antibiotic treatment, ACE, ARBs, statin, body weight, cigarette smoking, stopping all that. And then they are randomized into two groups. One group continue in this non-immunosuppressive therapy, 38 patients, and the other group added rituximab, 2 dosages, 375 milligram basically. The endpoint at 6 months, no difference. The proteinuria, ad hoc post 6 months later, there was some improvement on the proteinuria reduction around more than 50%, and there is some increase in serum protein. Observational study at 17 months showed that remission rate with the rituximab group was 65% versus 34% with the control group. No adverse effect were quite similar. And then the second mentor, which is the rituximab membranous nephropathy trial of rituximab, again comparing rituximab with cyclosporin in idiopathic membranous nephropathy, randomized controlled trial, 130 patients. Rituximab was given as 1,000 milligram infusion 14 days apart and repeated 6 months later if really proteinuria is still high. Cyclosporin was given 3.5 milligram per kilo. Again, in the same manner, the primary outcome, composite of complete and partial remission, 24 months. It's non-inferiority hypothesis. What happened, as you'll see at 52, at 12 months, basically quite similar. Rituximab was non-inferior to cyclosporin, but really when they are followed to 24 months, look at the difference. Rituximab was superior to cyclosporin, 63% versus 21%. The conclusion of the mentor study was that more frequent and longer remission with rituximab, similar rate of adverse event, but adherence was much better because you give the doses twice and then you know that your patient received the drug. To the contrary, with the cyclophosphamide, cyclosporin, there is a chance for not really complying with the drugs. So the mentor study established superiority of rituximab over cyclosporin as place of rituximab and perhaps first-line management for membranous nephropathy. But of note that the co-author of this study, Dr. Daniel Cattrall from Toronto, mentioned there is no head-to-head comparison with cyclophosphamide treatment, so which is the standard at one time. Move on to cryoglobulin. As you'll see, skin ulcers, GN, and others, where we stand. There is a very nice really study from hematology, and where they looked around 242 patients with cryovascular survey, 73 connective tissue related, essential cryo around 117, malignant 52. All of them have clinical criteria involved, but renal involvement was in 35%, that's highlighted in blue. All of them received combined therapies from alkylating agent, rituximab, plasmapheresis, and others. What's the outcome? You'll see here with I showed red stars. Renal involvement was the best really among all. And the protocols down, you'll see combination therapy with cyclophosphamide, with rituximab, cytotoxic agent, corticosteroids was the best response. And when they combine all of them, rituximab, cyclophosphamide, and glucocorticoids, again, it's much better than alkylating agents alone. Unfortunately, in the top right there was a high incidence of infection, well, most likely because of the use of high-dose steroid. There are some other randomized controlled studies showed superiority of rituximab for the treatment of such disease entity. Move on to some studies here. The lunar study, which is the best looked so far, when they have randomized controlled 144 patients, class 2 and 4, 1-to-1. They were screened and they were divided into two groups, add-on therapy, rituximab plus myclophenolate and myclophenolate plus placebo, and they followed up for 52 weeks. Primary endpoint was renal response status at 52 weeks, and they followed after that for 78 weeks. Look about top, there is no difference, complete remission, partial remission, and no response. Only in subsector of the group, the Hispanic and the Black American, when they have really a better advantage of rituximab than really what you have. So the conclusion of this, in lupus patient, there is no benefit of rituximab at 12 months. Then there are observational studies really for refractory cases of lupus nephritis, 26 eligible studies, 300 patients, about complete remission and partial remission. There is a good, decent response, and look about the mixed cases, 76% partial and complete. And conclusion of this was that rituximab effectively induced remission in lupus patients who have not achieved remission with standard therapies. Randomized control studies really should be done. Unfortunately, there is nothing there. Now, what about IgA nephropathy? IgA nephropathy, here there are one randomized control study, 34 patients, biopsy-proven IgA with certain renal diseases, 17 standard therapy of ACE, ARBs, blood pressure control, diet control. 17 received rituximab plus standard therapy, 1 gram infusion day 1, day 14, and repeated 6 months later, followed for 12 months. Primary endpoint was what happening there with the GFR and the proteinuria. There is no difference with rituximab group and control concerning GFR. There is no control. There is no difference proteinuria and rituximab concerning protein reduction. So the conclusion was rituximab depleted, yes, the B cells, but there is not really change in the result outcome concerning proteinuria and the creatinine. Results are not encouraging, and they came that IgA nephropathy is not really as a classic immune disease. Currently, there is a study going in Mayo Clinic looking for multi-center randomized prospective open label trial, but this study has been closed. The results really are not available so far. Where we stand with minimal change disease and other focal segmental, we know that the mainstay of treatment of minimal change disease is basically steroid therapy. In adults, the response is slower, the response needs longer time, but there are good evidence that it's really being relapsing, good number of relapses. And how we treat really frequent relapses, either we continue small dose of steroid for longer period of time, or we use other agents, and other agents basically alkylating agent, calcium urine inhibitor, myclophenolate, or rituximab. Now, rituximab in a systemic review, 14 studies, including 86 patients, showed decreased number of relapses, decreased proteinuria, increased serum albumin, and decreased urine immune suppression use in such patients. So it has a place. And there is a nice respective study in 11 patient real. Look about the incident in blue. Before rituximab, the incidence of relapse is high. After relapses, after treatment is quite low. Conclusion of that, basically rituximab is efficient and safe in adults suffering from severe steroid-dependent minimal change disease, and still we don't have prospective trials for this. Now, there is a role for really in steroid-resistant and focal segmental resistant? There is no convincing evidence for that. I'd like to conclude, Mr. Chairman, that rituximab is a valuable first-line treatment for ANCA, vasculitis, in newly diagnosed or relapsing cases. Also, it's good for maintenance. There is a good role, and it's promising result in severe mixed cryoglobulinemia Possible use as alternate first line of therapy in primary membranous nephropathy. May be used in steroid-responsive, frequent relapsing, steroid-dependent focal and minimal change disease. May be used in lupus nephritis when first-line therapies fail. Not recommended in IgA nephropathy, and there is no place for rituximab in steroid-resistant focal segmental glomerulosclerosis. I'd like to thank you for your attention.